Hey guys, welcome back to the channel. Today we are discussing the ARISE trial, Australian Resuscitation in Sepsis, Evaluation of Randomized Control Trial.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of some whatever. Under any circumstances, the author accepts no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of educational content.
Critical Bhushan in adult patient with septic shock does early goal directed therapy (EG.DT) compared with the standard therapy reduce the mortality at 90 days mortality. Design for the trial. This is multi-center unblinded randomized control trial. Permitted block randomization stratified by site to allocate eligible patient 1:1. Intention to treat analysis. Sample size calculation based on assumption in hospital rate of death in the usual care group of 28% with an increase of 38% by 90 days based on recent high quality studies. 1600 patients provided power of 85 to 90% to detect an absolute risk reduction of 7.6%. Setting for the study: 51 hospital, 45 in Australia, New Zealand, or 6 centers in Finland, Hong Kong and Republic of Ireland. During of the study is 2008 October to April 2014. Long duration of study was conducted. Inclusion for the study: 2600 patients. Then inclusion criteria for the patient: adult presenting to the emergency department with a suspected or confirmed infection and 2 or more search criteria and evidence of either refractory hypotension or hypoperfusion. Refractory hypotension, presence of systolic blood pressure less than 19 mmHg or mean arterial pressure less than 65 mmHg after a 1000 ml intravenous IV fluid challenge within a 60 minutes, including IV fluids administered pre-hospital. Hypoperfusion confirmed by the presence of blood lactate concentration more than 4 mmol or first dose of IV antimicrobial therapy commenced prior to randomization. Exclusion criteria: contraindication of central venous catheter insertion, blood product, inability to commence delivery of the EGD protocol within 1 hour of randomization or complete 6 hours of EGDT, hemodynamically instability due to active bleeding, pregnancy confirmed or suspected, in a patient transfer from another acute health care facility. In a patient, the patient has been underlying disease process with a life expectancy less than 90 days, death is deemed imminent and inevitable, limitation of therapy, order to restricted implementation of the study protocol. Baseline characters for EGDT versus usual care group: age is 60 to 63, Apache score 15 versus 15.8, lactate 7.7 to 6.6, site of infection 1/3 pulmonary, median time first dose of antibiotics following arrival in emergency department 70 minutes versus 67 minutes. Intervention in GDT group: early goal directed therapy, arterial line and central venous catheter capable of continuous SCVO2 measurement. Adverse life sciences was inserted within 1 hour after the randomization. Treatment algorithm was commenced based on reverse original EGDT algorithm, included supplemented oxygen if not already initiated or tried to achieve SpO2 more than 93%. 500 ml bolus of crystallite or colloid at least every 30 minutes until the CVP more than 8 mmHg self-ventilating or more than 12 mmHg on NIV or invasive ventilation. Vasopressor to achieve MAP of 65 to 90 mmHg. SCO2 more than 70 once the CVP and MAP target achieved. If SCO2 less than 70 and hematocrit less than 30, PRBC transfusion. SCO2 remains less than 70 despite of hematocrit more than 30 or HB more than 100 gram per DL, then dobutamine 2.5 to 20 microgram per kg per minute. If SCO2 still less than 70, increase the oxygen, take on NIV, or not maintaining on NIV, then mechanical ventilation. Sedative paralytic agent used in mechanical ventilated patients. Treatment algorithm continued for 6 hours. Intervention was provided by the study team trained in EGDT. Both care are provided and the location of delivery, emergency department or ICU or both were dependent on the local resources. Control visual resuscitation care. Arterial line CVC may be inserted if considered clinically appropriate. SCO2 measurement was not permitted during the 6 hours intervention period. Decision about the location of care delivery, investigation, monitoring and all treatments were made at the discretion of the treating clinicians. Outcome. Primary outcome. All causes mortality at 90 days after randomization 18.6% in EGDT versus 18.8% in usual care group. Subgroup analysis, no difference between the countries, Australia, New Zealand and others. Secondary outcome, median length of stay in the emergency department 1.4 hours in EGDT, 2 hours in usual group. Hospital and ICU length of stay, no difference. The need for the duration and organ support, vasopressor requirement in EGDT 76.3 versus usual care group 65.8. Median duration of vasopressor infusion, no difference. No difference in number receiving mechanical ventilation or RRT. Tertiary
mortality at ICU discharge stay 3.9 versus 12.9. Hospital mortality 14.5 EGDT versus 15.7. Volume of fluid administered during the first 6 hours 1604 1964 versus 1730 ml fluid administered during the 6 hours. Subgroup analysis, no difference in any categories, country, aperture score, presence or absence of invasive mechanical ventilation, presence or absence of refractory hypotension, lactate level less than or more than 4 millimoles, intravenous fluid administration less than 20 ml per kg or more than 20 ml per kg of body weight. Primary outcome and secondary outcome in tabular form. 90-day mortality, EGDT usual group, major vasopressor, emergency department, length of stay in ICU, length of stay, hospital length of stay, and 20-day mortality. Only 1% difference in EGDT and usual group primary outcome, and 20-day mortality also is of 1% only difference. Strength of the clinical trial, clinical relevance and high impact, large multi-center study, use of original EGDT algorithm in the intervention group, a pragmatic study which allowed the clinician discretion in managing the usual care group, and also not a limiting involvement of some center because of resources limitations. Information supplied regarding the timing of one dose of antibiotics, sensible inclusion criteria of antimicrobial being started before the involvement, address the potential confounding effect, led administration, subgroup analysis for variation in mortality between the countries, statistical analysis plan published before the requirement was completed, eliminate the risk of analytical bias, weaknesses lower aperture score than process and reverse study, but this has been addressed with the subgroup analysis of those with aperture score less than 25 or more than 25. There was a Still no difference in mortality between EGDT and usual care group. In the seeker group, although the total number were small, more than 25 groups, low recruitment rate per month across all centers. Largest recruitment center is Austin Health, reported at the mean rate at the just 2 patients per month. However, adherence with EGDT protocol was high and management of sepsis well established in usual care practice. This low rate reflects the complexity and conducted research study. Multi-center involvement is essential for ensuring the gender stability and appropriately powered to thrive. After conclusion, in critical inpatients presenting to the emergency department with early septic shock, EGDT did not reduce all-cause mortality at a 90 days. Bottom line for this study, another nail in the conclusion of EGDT, especially continuous fetal venous co-oximetry, liberal blood transfusion policy probably determined. Despite the stark difference between the process and arises compared with inborn paper, it is essential that we continue to recognize the importance of high standard care in the safety. Early recognition, source control, antimicrobial therapy, fluid resuscitation, and aspiration remain the fundamental treatment goals. I eagerly await the result of the promise to complete the terminal variant and modern EGDT in a sepsis time.